Welcome, everyone, to APTA Live Student Night. My name is Dr. Lindsay Durand, and tonight's topic is how PTs and PTAs can play a role in the opioid epidemic. For tonight's discussion, we are joined by Dr. Jake Magel and Dr. Eric Kruger, who are well-versed in the topics of chronic pain management and the opioid epidemic, and we will hear their insight as to how students and professionals can make a difference when it comes to this. I will give our guests an opportunity to introduce themselves and give a bit of their background before we start talking about chronic pain and the role of PTAs. But for everyone tuning in, go ahead and introduce yourself in the comments. Tell us what year you are, where you go to school, or where you're tuning in from. And if you'd like to spread the word about this event, tell us what you think and continue the conversation, go ahead and use the hashtag APTA Live. And if you don't follow us on social media, you can follow us on Twitter at APTA Students and on Facebook and Instagram at APTA Student Members. And if you have any questions throughout the discussion tonight, please drop them in the chat and we'll pass them along to our guests to answer. So we'd love to hear your thoughts. Don't be afraid to ask questions and interact with people throughout the comments. Now, let's get to know our panelists. So we will go ahead and bring on Dr. Jake Magel and Dr. Eric Kruger, who will give us a little bit of background on who they are, what they do, and how they kind of got into this role of addressing the opioid epidemic. Did anyone want to start?
I can start. I'm Dr. Kurger, assistant professor at the University of New Mexico. I've been in this position for about 3 years. How did I get here? It's a good question. I practiced in orthopedics since about 2007, before going back to get my PhD in psychology, primarily out of interest of pain and psychology. And it just so happened that the institution, the University of New Mexico, where I did my PhD, there was a focus on addictions, and this was also occurring at the height of the opioid epidemic. And so I kind of got involved with research related to that, as well as research related to pain. And I think as I was reflecting a little bit about also kind of what's pulled me further into this area, I can think about my experiences as a clinician, and probably to some extent not feeling adequately trained to work in this area, and thinking about some of the patient experiences that I had and how I kind of navigated that, and wanting to provide a better training for our current students and our future students. So that's kind of the short story of how I got here. Jake.
So I'm Jake Magel, and I'm a research assistant professor at the University of Utah in Salt Lake City. And I, for nearly 18 years, treated patients with musculoskeletal conditions and plenty of patients with chronic pain, and patients who have been using opioids to manage their condition, and both pre and post surgical patients taking opioids. So I have a lot of clinical experience in that, and I became quite interested in getting my wanting more to contribute to the actual evidence. So I got my PhD here at the University of Utah, and became more and more interested in opioids as an outcome of the care that physical therapists provide, and have partnered with some addiction medicine specialists here at the University of Utah to look at patterns of opioid use after spine surgery, and with an eye on how physical therapists might be able to impact that opioid use after spine surgery, and really have a big interest in how physical therapists can play a larger role in helping to solve this opioid epidemic, and that has led me to do some survey work among physical therapists, and finding out their attitudes and beliefs related to managing people with opioid misuse and opioid problems. And so that's essentially how I got here.
Great. And that's actually that survey that you mentioned, Jake. That's actually how you met Eric, isn't it?
It is. That is how Eric and I met. And Eric actually was one of the people that took the survey, and he reached out to me after that. And then Eric and I partnered recently on on a commentary that was published in Substance Abuse Journal that really focused on patients who were potentially maybe misusing opioids or using them chronically, and we just sort of gave our thoughts on how physical therapists might play a larger role in managing those types of patients, and that was just recently published in Substance Abuse Journal within the past month and a half or so.
That's great. We'll have to. I definitely need to check that out. We keep mentioning the opioid epidemic, but for those who may not know or may not be aware of the opioid epidemic, can you all give a little bit of background on what it is, kind of how it came about? What exactly are we talking about here with the opioid epidemic?
Well, I'll go ahead and take a quick start at that. Well, since the 90s, there was a big effort among pharmaceutical companies to train physicians to manage their pain, and opioids were obviously a big part of that. And that was right around the time when I think it was the American Pain Society identified pain as the quote unquote fifth vital sign. And there was a big effort to say, gosh, if you're not managing somebody's pain properly, or if you're not managing their pain, then you're potentially doing the patient a big disservice. And so opioids really got pushed. And Purdue Pharma came out with OxyContin right about that time, and they really pushed hard with training physicians and nurses and pharmacists to really get out there and push this product. They gave tremendous incentives to their sales staff to push the product, and it was kind of the Wild West then with opioid prescribing over time. And then in the mid like 2006, 2007, and so on, that's when we really started to see problems with opioids increase, and lots of people have become addicted over time, and opioid use has just the use of prescription opioids has increased rapidly over the years. And actually, it's gone down somewhat over the last 2 or 3 years. But boy, if you're taking prescription opioids, then you're a lot more likely to, or that I should say that most people that actually, 3/4 of the people that are taking heroin start with prescription opioids, and so it's become a big problem, and it's become a problem that physical therapists, I think, have a major role in helping with.
Yeah, and I'll just add to that. I think one of the other things that has changed in the landscape of opiates is the development of synthetic opiates, like fentanyl. And this, obviously there's a medical side of that, but these synthetic opiates are much more potent than any other kind of delivery mechanism to date. And they also have been sort of co-opted by sort of the illicit trade of drugs, and sort of has infused the markets in ways that has probably exacerbated things in combination with this. So I think that there's a part of it that medicine has been involved with in terms of, as Jake outlined, but there's also this other part that we're now sort of dealing with, and we're seeing in the data where, as Jake mentioned, opioid prescriptions are decreasing, but we're seeing overdose deaths, double, increase, and so we have a kind of a magnifying problem here with that, and that largely is due to kind of fentanyl coming in a variety of streams and different drugs, things like heroin that were purely heroin are now cut with drugs like fentanyl, and this creates issues because these are not pharmacies doing this, and therefore people get large doses of this very potent opioid. So yeah, it's probably a variety of factors, also challenges within our communities as well, psychosocial challenges as well have also hit. But yeah, so it's a multifactorial problem, and yeah.
Yeah, kind of following up on that, what exactly in terms of those biopsychosocial factors are going to make people more susceptible to potentially like a drug addiction or become addicted to opioids? I don't know if you have the answer, but
yeah. So I mean, I think if you have, you look at those adverse experiences, or sometimes abbreviated as ACEs. If you have a history of those, sort of this idea of like trauma-informed care is one. If you have a history of any exposure, if you have a previous history of kind of substance use disorders and now you're prescribed opiates, that's another one. Let's see here. I'm going through my head. Jake.
I think that yeah, if you've been prescribed an opioid, you're much more likely at some point to go on to have some type of opioid use disorder than if you've never been prescribed an opioid. I just wanted to point out before we answer go further into this question, is that I'm sure that many of the people watching this now, or who will watch this in the future, have been touched by this in some way. And either some of you directly might have had experiences with opioids, or family members or friends or people in the community. And it wasn't that long ago that here in little town just right near where I live, called Park City, where two young kids about the age of 15 ordered some fentanyl from someplace in China, and two kids lost their lives just in the last, this is probably about a year and a half ago. And so it's a pervasive problem.
Yeah, and other psychosocial factors are things like history of depression, other histories of kind of mental health conditions, history of alcohol abuse, familial history of alcohol abuse, or other sort of prescription drug use, or some other kind of major factors. Yeah, and I'll just echo that. I mean, in the last year or two, we've had people very close to us with some struggles related to this in ways that, I wouldn't have expected, 5 or 10 years ago. So I think more and more people are being touched by it.
Absolutely. I think it is kind of a growing problem. And from what I've heard, especially in patient care, which I haven't, as we were kind of talking about before, I haven't been in patient care all that long, just a few months. You really do hear from almost everyone that they have been touched by the opioid epidemic in some manner, whether that was a friend or a family member, or potentially themselves. It really is a growing problem. And kind of like you brought up, Eric, it's not just like the being prescribed opioids, it's things going on, outside of the medical scope of practice. So what exactly is the PT profession attempting to do in terms of the opioid epidemic? Like, what is the Choose PT movement really about? Those might be two different questions.
Jake, I think this is a great one for you.
Well, Choose PT is really an effort to try to get patients, particularly with chronic pain, to use PT as a first-line management strategy rather than get on opioids. And so that's really the upshot of Choose PT. And I think that we play a major role in managing pain. And so we certainly, there's evidence that when a patient accesses a physical therapist, that particularly if they access a physical therapist early, then they're less likely to initiate an opioid down the road. Or if they access a physical therapist compared to maybe a PM&R physician or even primary care in some more recent work, that if they see a physical therapist for low back pain compared to these other frontline professions, that they're less likely to initiate an opioid and maybe even less likely to be on long-term opioids in the future. And so physical therapists play certainly a major role. And there's been some interesting work by Todd Davenport, who published something in PTJ that really outlined the physical therapist profession in relationship to prevention of opioid use disorder, and so gave physical therapists some really good things to think about in terms of how we can number one, prevent chronic pain to begin with by managing the patients appropriately. Number two, keeping an eye on the patient, recognizing signs of potentially signs of addiction. Number three, referring the patients when they should be referred. And so we have a huge role in preventing opioid use disorder. But I also think we have also a large role in watching out for people who might be potentially misusing opioids, which is different than addiction or different than opioid use disorder. Opioid misuse is just using them differently than prescribed, in any way other than prescribed. That is a risk factor for developing opioid use disorder. And so really keeping track of how the patient is using their opioids. Are they using them appropriately? Are they using them in the right dosage? Are they describing themselves as getting high from them in some way, or having feelings of euphoria, and therefore they're taking more than they potentially should? That's a sign of potentially opioid misuse, not really addiction, but potentially opioid misuse. And PTs certainly have a role in that. And so in identifying that, and then bringing it up to the patient, talking to them about it, and potentially referring the patient to an addiction medicine specialist, certainly back to the referring provider if they have one, and alerting the provider to those potential issues. And so I think PTs have a role in preventing patients from getting on opioids to begin with, and when the patients are on opioids, helping to make sure they're using them appropriately.
And I'll add to that. I think, thanks, Jake. That's an excellent summary. I think, as we think about the challenges of this ongoing opioid epidemic, and like I mentioned earlier, issues with like fentanyl. I heard someone talking today. I was talking about it. They called fentanyl the Delta variant of the opioid epidemic, and maybe we wouldn't have known that metaphor, a couple of years ago, or a year ago, but now that's what we're dealing with. But I think it kind of encapsulates part of the challenge is that there's going to be a large, maybe not large, but a significant percentage of patients that have had some exposure to opioids and have struggled with just opioid use and misuse, and they're going to be seeing physical therapists for maybe a pain issue, maybe an orthopedic issue, maybe none of these things. Maybe it's a spinal cord injury or a neurological condition, a cardiovascular. And as physical therapists, we have to figure out ways to start supporting them in along their healthy behaviors in their own health. And we have to have ways to have discussions with them. And I think, these patients are also going to be seeing, they're going to be getting procedures done where they have to have acute pain management. Like, let's say they go in to have a total knee or some, abdominal surgery. They're going to be given opiates, likely for that acute pain management. And they need providers around them that are supportive and understand their history and that know the referral pathways and the people that can help them out in addition to the physical therapy that they're doing, and be able to have the conversations with patients about these things in ways that are non-judgmental, non-stigmatizing, that are matter of fact and professional. And that can be challenging in the environment that we live in, because there's been a lot of stigma associated with opioid use or just drug use in general. And so those can be challenging conversations to have, that people don't necessarily, they don't wear those on their sleeve like they do, the scars from an ACL surgery or something like that. They don't want to readily admit these things if they don't feel safe. So we have to figure out ways to, but I think us as physical therapists are also in a place where we have this tremendous ability to build therapeutic rapport and therapeutic alliance through the number of sessions that we do, the number of contacts that we have, the time we spend. So, I think our profession is well positioned in a way that's pretty unique in medicine. I mean, you think about post-operatively, when you see, just speaking from an orthopedic perspective, you have a surgery, you might see them or their PA like a month later, or maybe immediately afterwards, and then a month later after that. That's not very many contacts, and we might be seeing them every week, maybe multiple times a week. And so we're in a position to really kind of track and see where that patient's struggling, to talk about that. So there's a lot of ways, where it's just kind of creating that dialogue with the patient about this, and knowing that, and letting the patient know that they're safe, that they're not going to be judged around this. And then you get a feel for what's actually going on and what they, so that's kind of an additional area. I don't think that we've really figured this out yet. I mean, when I look at the research and kind of what's been done, it's, a lot of it's been on the tapering and the, reducing opioid prescriptions. But now we're starting to say, okay, this is, we're going to have to do more. And our healthcare system is, as many of us know, is kind of siloed in a lot of ways. We don't work in interdisciplinary teams. And so we're going to have to figure out how to create these sort of, taking on a little bit more as a profession, because we don't have immediately someone that we can refer to, or we're gonna have to build those referral pathways and reach out and figure out where those are. So in ways that maybe we didn't have to do 10 or 15 years ago. I can certainly say from my personal experience as a therapist, and remembering some patients early on when I was just a new grad coming out of school and being totally, I wouldn't say overwhelmed, but kind of shocked that, how in particular, one patient that I remember was sort of at some point I knew that they were taking opioids, but I didn't really delve into that conversation anymore. And then I saw them progressively over a long period of time, and then they decided to do something about it. And I was sort of surprised that this was a thing that they would choose to do. I mean, I kind of knew that, it was something to be concerned about, but I didn't realize the patient had brought it, had noticed it being something that they were concerned about before I was. And I think that's got to change. And I think it probably has changed in a lot of ways, but we still don't know. And that's kind of the work that Jake has been doing, is trying to figure that out. What do we actually know as a profession about what's going on in clinical scenarios, and what do PTs think about it?
Yeah, I'll just dovetail onto that, if it's okay, Lindsay.
Yeah.
We some colleagues and I recently surveyed physical therapists who are members of the Academy of Orthopedic Therapy, and we surveyed them on their some of their attitudes and beliefs of managing people who were either misusing opioids or had opioid use disorder. And what we found really was that the vast majority of physical therapists, about 82% of physical therapists, believe that we have a role in managing patients who are misusing prescription opioid medications. But that very few of us are actually trained or have any training in how to do it. So when we surveyed them, about roughly 30% reported that they had 0 hours of any type of training at all. And then another 50% on top of that had between 1 and 6 hours of opioid misuse training. We didn't make any effort to define what that looked like, or what the quality of the training or anything like that. We just said, have you had any hours of opioid misuse training? And so a large proportion have 0, and 50%, an additional 50% have just a few hours. And so I think there's a lot of work to do in terms of training physical therapists how to communicate with patients who are taking opioids, taking them properly even. And then just like Eric said, really communicating to people in a non-judgmental manner so that you don't promote stigma of taking opioids. And so there's a lot of work to be done there. And so that's some of the stuff that I'm interested in too.
And part of the challenge with that is, as I'm hearing you talk, Jake, it's, because I teach this stuff in our curriculum. So as I think about it, it's like, we might teach these concepts or concepts of communication in our curriculum, but really where the students learn this stuff the most is through the interactions with their CIs when they're going out on their rotations, and they don't necessarily have the training. So like we might teach a concept, but then to see that modeled, or it's still like that gap needs to be bridged too. We need to train our CIs. It's kind of like the chicken or egg concept. It's anytime you want to make a change, you have to look at what happens when they actually go out in their clinical rotations, and so that's another piece of it as well.
Yeah, I think you all bring up just really great points on the types of different patients, the way that PTs can kind of intervene in the process. And I remember even as a student, especially my last clinical rotation, for whatever reason, I had quite a few patients disclose that they had either previously been addicted to opioids and were undergoing treatment for it, or that they were currently addicted and needed to go to rehab services. And that was something, as a student, I felt like I had no training. Even now as a new grad, I have no training experience. I have no idea what to say, how to react. So I don't know if you guys have thoughts for any of the other students who may experience this on clinicals or new grads kind of tuning in, but how should a physical therapist or a PTA kind of respond in this situation? What would be kind of the appropriate path or recommended services that we then send that patient to?
Go ahead, Eric.
Well, yeah, I don't know if there's like a best practices. I think it really depends on the context that you're working in, the context of how the patient's coming to you. Are they coming to you direct access? Are they coming to you through a physician referral? I tend to tell our students, if they came through our physician pathway, then that should maybe be our starting point of contact, at least to start with. And depending on how that goes, it's always something I think you want to do in collaboration with the patient. You don't necessarily want to, if the patient, let's say, as you mentioned, Lindsay, the patient is contemplating, knows that they need to make a change. They're ready to make a change, and you bring that up to the physician, but physicians, maybe they're not getting the support there that they need. Then maybe at that point you decide to extend beyond them and look in your area in terms of what kind of treatment options there are. In terms of who you can refer to, the health system that you're working in. If you're in an integrated system versus a solo practice, it may look very different. You might have referral pathways. You might have clinical social workers or care navigators, or you may have a psychologist or behavioral health specialist within your system that you can easily kind of loop them in with. In other systems, that might not be the case. And so it's more fragmented that way. And then even from a rehabilitation, there's kind of, in psychology, there's a lot of different kind of types, and not every type jives with every patient. So I think thinking about, so I think that can be a challenge as well. And so, there's a variety of challenges. I think I'm trying to think if there's, so I would say starting and looking at what are your resources, and looking immediately around you, and then kind of branching outwards, and try to build some professional relationships outside the clinic first with different specialists or social workers or behavioral health specialists. If you're feeling like this is a need in an area that you want to really assist your patients in, and get a feel for what they're doing, and that will maybe be a good starting point.
I think that's a great place to start, and we really need to acknowledge certainly that many of the physical therapists who might be viewing this or will view it might be working in practices that are not attached to healthcare systems. And so sometimes those creating those relationships where you can get support to help manage to refer patients that you think might need additional treatment related to their opioid use is critical. And so what Eric pointed out, by really looking around you and trying to identify those resources is critical. Gosh, that's not easy if you're working in a rural environment, in the out in the country, and there are a few resources to begin with, and so but it's not up to you as a physical therapist to be the person's it's probably not appropriate for you as the physical therapist to be the person's only provider when it comes to something, when you think that when it comes to the patient that you suspect is misusing or addicted to opioids and they're not under treatment somewhere else. It's up to you to find out where to send that patient, and identifying those referral sources and support for you is really important.
Absolutely. We'll continue this discussion on resources after a few quick announcements, but we're going to take a quick break here just to kind of go over some things happening within APTA students. So if you haven't seen, voting is open for the APTA Student Assembly Board of Directors for the 2021-2022 year. So voting will be open until November 6th, and all student members are eligible to vote. So you can check out the APTA website or your email for instructions on how to cast your ballot. And this year, everyone who submits a ballot or casts a vote will be entered to win free products and subscriptions from Score Builders. So definitely be sure to do that. Like I said, voting will close on November 6th for the 2021-2022 Student Assembly Board of Directors. Additionally, registration is open for CSM 2022, which will be happening in San Antonio, Texas. So again, check out apta.org for more information on CSM registration. Additionally, Fit for Practice sign up is still open. So if you're interested in receiving weekly emails from APTA on how you can stay healthy physically, mentally, emotionally throughout the end of the year, be sure to check that out. Again, that's called Fit for Practice. And 100 days of service is running through the end of the year. So if you're doing a project or a service assignment in your local community and would like to let us know about it, you can list it on the Centennial website. So check out APTA for more information on that. All right, we will go ahead and bring back our guests. And so we did have a question from the audience. This is from Alice, and she said, there may not be an answer to this, but is there something we can do for our patients, especially ones who can't afford their copay for physical therapy? What if opioids might be the only affordable pain management option? Where or what resources might we be able to provide to bridge that gap as PTs or PTAs?
That's a great question. And, copays are not getting cheaper most of the time. And it really speaks to managing the patient based on the current best evidence and providing effective interventions up front, and really doing a thorough examination and managing the patients based on that examination in a way that understanding that you might have very few visits with this patient, and being able to educate them in ways that they can go home and manage their pain on their own. Identifying community resources for exercise, identifying gyms in the neighborhood, community centers that might have ways to kind of work as an extension of you. And I don't think that the copay problem is necessarily problem is the only just the problem for patients with who are taking opioids, but certainly is a problem throughout physical therapy. But I think using effective intervention strategies for these patients that is most likely to impact their pain, and effective education is critical. If they're not going to be able to come in, you better be treating them right.
Yeah, I would just echo what Jake's saying about valued care. I think one of the things that you can do as a physical therapist, if this is something that you see often in your practice, is that you're screening for social determinants of health and the financial ability for patients to pay for your services, and you do that from the standpoint that so you can have a conversation up front really early about the valued care that you want to have with them, and have a collaborative session about what you think you can do with the limited number of times that you might be able to see a patient. So I think when we think about what Jake's saying about types of interventions, it may make sense if you know that the patient's going to be with you for a visit or two because of issues like financial strain and inability to pay copays, and there's not other options out there. There may be other options, but just say that for the purpose of this discussion, they're not, is that you decide to go more, discussion based about, pain education and getting people set up on so they're not. So you do the musculoskeletal screen and your differential diagnosis, so you make sure that they're appropriate for those things, but then you immediately go into kind of giving them the resources for self-management. And so I think there's some things that we can also think about related to other types of self-management tools that we can give them that are outside of our traditional toolbox, maybe things like mindfulness or other types of cognitive behavioral treatments that we're starting to think about and incorporate more into our treatment regimen. But it's, again, a little bit heterogeneous, and I think a lot of PTs are unsure about how to do that. And so those are some potential ways, but it's a huge challenge. It's a huge challenge. It's definitely not ideal or optimal conditions when our patients can't afford appropriate care and really care that transitions settings, whether that's, from the PT to sort of a community-based system or from inpatient to outpatient. Those transitions are really pretty terrible, in terms of continuity of care. So, yeah.
Absolutely. In your guys' opinion, who would be the ideal team for a patient who is undergoing either opioid misuse or has an addiction to opioids? Who would you like to see as part of their healthcare team in an ideal setting, of course?
I think some type of behavioral health specialist, such as a psychologist, doesn't have to be a psychologist, a social worker, or a counselor that's experienced with substance use disorders, that has a good therapeutic alliance with the patient. I think obviously someone that can medically manage them appropriately. I saw a question in the chat about methadone assisted treatment, or we think about medication assisted treatment being methadone or buprenorphine or Suboxone, as sometimes people understand it by. But these treatments are can be really effective for our patients, and one, PTs having the knowledge of them and not to look at them from, oh, this patient's on methadone. They're attaching stigma to those things. I've certainly heard that in my clinical experience as a PT, listening to other PTs chat in the past. And so I think we have to figure out how to make PTs aware early on so they don't build these biases in and things like that. But so I think someone that can medically manage the patient effectively, they have psychosocial support, they can be connected to services in the community that's kind of the role that the social worker can play as well. And then, PTs can the interesting thing is, if the patient has pain, psychology doesn't train a lot of psychologists to be pain specialists. And so there's a bit of this gap here between psychology and medicine or physical rehabilitation. And, there's a lot of PTs that are thinking a lot more about the psychology of pain and the psychologically informed practice. And there's some psychologists, and there's, a gap in the number of providers that have that specialty. So I think we as PTs can take on some of those things when we've got them attached to, physical outcomes in ways that, where we can show either greater participation or less functional, less activity limitations, things like that. We may not necessarily see their pain go down. I think, I'm sorry, going all over the place, I feel a little bit, but so I think I've kind of hit the major people that you'd want to have involved.
And I agree with that, Eric. And I also think that probably generally PTs aren't as involved as they should be in most circumstances. Because of this problem with siloed care. Here at the University of Utah, we've got a pretty good thing going where in our chronic pain clinic, where lots of the patients have some addiction problems, they're medically managed. They've got, I think, 3 physical therapists in-house, and they also have social work and psychology, all in the same space. And so they're communicating with one another all the time about their patients, and that really creates a situation where it's really working at the highest level of their practices for the on the patient's behalf, being able to communicate with one another, and so I think that's a pretty good model. But I agree that even out in the community at some of these addiction centers that are sort of outside the system, there should be physical therapists in those or some kind of if it's not a physical therapist helping to manage the patient and some of the psychological aspects of pain, then at least somebody who's helping to exercise the patient, get them moving again, and because there is some evidence that exercise can help people who are addicted to substances abstain from using them. It plays a role in that.
And I would just follow up, Jake, if that's all right, Lindsay. That one of the challenges, it's not just PTs, but it's broadly this split between individuals with pain and individuals with substance use disorders or opioid use disorder, is that the treatment has historically always been separate. They haven't been integrated at all. And we're seeing, so the NIH has this HEAL initiative. It's like a sort of interinstitutional research initiative looking at chronic pain and substance use disorders, and what they're specifically looking at, and have put recent calls out for research related to, is these integrated programs that look at both individuals with chronic pain and substance use disorders. And we haven't, from a provision of care, the way clinics are set up historically, there's been very few, if any, that have done that. So that creates a number of problems, and we could talk about this a lot, I think, but suffices to say it's historically been separate, and a lot of that, it's complicated too. Sometimes it's like billing. It's like, how do we even get, even if you have this idea, like, it's like, how does the institution support having this physical therapist, this other provider in this totally different treatment setting? So there's going to be a number of challenges related to that, but I think we're starting to move in a direction where we're going to hopefully be seeing more of that and having some research to support it.
I'm realizing this topic is much more complex than I realized, just hearing everything. And you guys bring up such great points in terms of, like, there's chronic pain, and then there's opioid use disorder or misuse. And then there's also patients who have potentially recovered from a substance abuse disorder. Maybe they were, addicted to opioids previously, or another type of drug or alcohol, whatever, and they're in recovery, but now they're suffering from chronic pain. And that, I think, brings up a whole different conversation as well. So I'm seeing it basically as these, like, 3 categories, and how PTs can make a difference. Like, patients who are not yet addicted to opioids, ways that we can step in and prevent people from taking them in the first place. people undergoing either active treatment or currently addicted, and then people who are now in the recovery dealing with chronic pain. Hopefully that makes sense.
Well, it's interesting. Oh, sorry, Garrett, go ahead.
Oh, I was just going to say it. I think we should say too here, because so there's a portion of patients that have chronic pain that manage their pain using opiates, and I think we have to be very aware that might be an effective option for them, and maybe the only effective option. We don't really know at this point, I would say, but that we have to be very careful and not stigmatizing them, because they can look at, I mean, they've felt this, they feel that the change in the way the providers are and pharmacists are behaving now, that they're being punished or treated are being stigmatized. And this, if you go to any kind of patient chronic pain group, you might see a lot of discussion related to this. And I think, so going into this and knowing this as physical therapists, if we have to be very, very sensitive in how we bring up these discussions and doing it in a way that doesn't look like we're, judging them or non-judgmental, but we're also not affixed to a certain outcome that they absolutely need to be reducing. Obviously, taking some amount of opioids probably puts you a little bit more at risk, but I don't necessarily think we know for sure, because lots of people are exposed to opiates, but not everyone develops substance use disorder, because that is a more complicated thing, and that could be a whole sort of discussion in itself. But I think I do want to make sure that we try to eliminate any bias, because I think that it's easy to say opiates are bad. We need to get all our patients off opiates, and then we have chronic pain patients that are taking opiates, and if we bring that to them in a way that they can react potentially very negatively and have almost a harmful relationship, because then they're not participating in physical therapy anymore. If they withdraw from physical therapy because they're unhappy about you bringing this up in a specific way, then that actually is kind of like a harmful relationship, because then they're not potentially getting the physical therapy that they need. So there's this idea of in substance use areas called like harm reduction, where it's like a really a flexible approach where you really put it's been around for decades, but a lot of, in the United States, it's been an abstinence-based approach to a lot of substances. Like prohibition can be one example of that. And harm reduction, instead of putting the emphasis on the reduction of substance use, the harm reduction is the reduction of harm. So it's a different set of behaviors than always, and it's more flexible. It's kind of meeting the patient where they're at, which is what we try to do, but sometimes we could get these biases built into our kind of ways that we talk and the ways that we carry ourselves. So just something to be aware of. Sorry about that. That was longer than I expected, Jake. Go ahead.
No, that's great. I love the discussion. I was just going to point out that we looked at Utah's all-payer claims database, which is a database where if an insurance provider insures more than I think 2,500 lives, then they're obligated to submit their claims to this database that we can then use to study patterns of care. And so it's for everybody in the state of Utah. And so about 80% of the population of Utah's their claims are in this database. And so we recently looked at it and looked at, if you had low back pain and you had a history of an opioid use disorder, how likely were you to go to physical therapy for that low back pain? And you're a lot less likely to go if you have a history of a substance abuse disorder and you have low back pain. You're a lot less likely to go to PT. So we have these patients that potentially already have opioid use problems, and they've got pain, and they're not actually. This is at least some evidence to show that they're not actually potentially seeking care for that pain from conservative providers. We didn't look at chiropractic. We weren't able to look at massage therapy. We weren't able to look at those other professions. But but at least attending physical therapy for back pain, which is a common route, these people are less likely to do it. And so, again, that I think shows that we've got some space to help these people, both with their chronic pain, and they might not be accessing care for it.
Sure. Jake, do you have any ideas on how we can kind of start to bridge that gap in terms of either like education for our communities on what we do, or just ways that we can reach these patients? I mean, Eric, I don't know if you have thoughts as well.
Well, I think
go ahead.
I was just going to say that traditionally we've been terrible at advertising our services and letting the public know what we do, and I think that a lot of that is really our own fault, because there's been a tremendous amount of variability with which physical therapy is provided to patients with all kinds of different conditions, and so we look at trying to enlighten the community, like the public, about what we do. Well, we oftentimes have a very difficult time even letting providers that refer patients to us know what we do, because you can have a patient with low back pain go to 5 different clinics and they might get 5 different things. And I think that variation in clinical practice is not a good thing for us. But in broad strokes, I think that we as a physical therapy profession, at the top levels of the profession, at the level of the APTA, probably we could do better at advertising to the public. Let them know that we're movement specialists. Let them know that we manage patients with chronic pain. Let them know that we are a frontline provider and an alternative to opioid use. That's what Choose PT is about. But you know what? It's awfully hard. I bet you if you polled the public here in Salt Lake City, if they knew any of that, and they basically say no. So I don't really have the big answer that's going to solve that.
I think it's definitely going to be a collective effort.
Yeah, I think approaching it both from the collective and the individual patient interactions, I think there's a lot we could do to, incorporate more behavioral, kind of like a behavioral health perspective in PT curriculums, focusing on, I try to get our students to think about participation. I think PT's like, okay, talking the ICF model here, if you're not familiar with that, but like, okay, body structure, function, impairment, activity limitations. This is like our, bread and butter. We understand this relationship really well, but like behavior change, to me, it comes, at when we're talking about the level of participation, and that kind of bridges that gap from that individual provider, but to this broader community that can support kind of healthy behaviors in our patients. And I think we don't, as a society, have a lot of these things set up in ways that are meaningful. It's interesting. This is not specific to opiates, but there's a family medicine doc here who runs this like running medicine thing, where it's kind of training this different culture around movement and running, and builds this community. And I think about that a lot as things that, I think our pockets were doing this in, public health initiatives, but like really creating these cultures and these kind of more community-based interventions. As PTs, we're not trained that way. We're trained one-on-one. But, in society, we have to bridge that gap between society and us as PTs and this individual interactions. I think we've traditionally operated in the medical model, very tight one-on-one patient care interactions. But I think when we're talking about societal epidemic of this magnitude, we're gonna have to think creative about our solutions. It may not necessarily always come in a one-on-one package, or at least part of it can come there, but we have to link it to the bigger kind of community-based interventions. And I don't think we figured that out at all. So that's not our fault necessarily. there's a lot of other things that related to that, but but
I'll just be a little provocative here and also say that we have we could be a part of the problem in the patient developing problems with opioids. opioid misuse, opioid addiction, opioid overdose, in that if we are not managing the patients appropriately, then it is possible that because of our the physical therapist mismanagement of the patient, not treating their acute pain properly, educating them in the wrong ways, using language that's not appropriate for the condition, that we actually perpetuate this patient's pain, and that patient could then go on to need opioids potentially because of our inappropriate management of the patient. I think that's possible. And so I think that's really important for the physical therapist to think about what happens to the patient once they leave this clinic. Okay. We're responsible for part of that. We're responsible for, are they partially responsible for whether or not they're going to have surgery? Okay. Whether or not they're going to have an injection or an MRI. Physical therapist we have a role in that, but we also have a role in whether or not this patient gets sent down the wrong road to potentially misuse opioids and potentially overdose. And so I like to let our students know that, hey, we have this role in prevention. And if we aren't hitting on all 8 cylinders when we're managing our patients, then we could be a part of the problem too.
And I'll just real quickly add to that, Jake. That's an excellent point. I think, focusing on pain, part of our role can be educating people about what life is like with chronic pain, and that doesn't necessarily mean it has to be as restricted as you think, but our patients are seeking this relief all the time from pain, and partially opioids provide that, and or it could at least be the starting point. And as PTs, when we talk about pain education and other things like acceptance, which again, whole big other topic, but appropriate care can help reduce that distress related to their pain, and therefore perhaps that need to seek that immediate relief when it's maybe something that they're going to have to live with the rest of their life. So it can teach them more effective ways to live with their pain. So I know we're running short on time here, so I'll stop.
No, I think this has been a great discussion. And I know we didn't get a chance necessarily to talk about chronic pain, so I'll just toss out for anyone who's watching this and wants a little bit more insight on chronic pain. We did have an APTA student social, I think earlier this year, with Adrian Lau. So you can find that on our YouTube if you wanted a little bit more information related to chronic pain and how PTs and PTAs can address chronic pain in that manner. But I do have one more question for our guests tonight. And it is related to, as students, because there's a lot of students watching, a lot of pre-PTs, potentially even new grads watching. What can we do like right now or start to do as students that's going to positively impact the opioid epidemic? What would be your hope for us?
I listen to patient stories. I try to go on YouTube or there's other websites, hear the stories read books on it, because you're not going to necessarily find it in the textbooks that we give you in PT school, but there's lots of good resources out there. There's movies about this now, and start digging into that and looking into that. I think it's a good starting point in understanding their perspective and the challenges in their communities.
Yeah, believe the patient when they tell you that they have pain, and patients that have chronic pain, believe them. And as a part of your profile on the patient, understand their current patterns of opioid use, so that then if you see something that is potentially amiss, that you can bring it up to the patient and potentially refer them to somebody that can help them. And identify the resources in your community.
Yeah, I think that's great. Again, for any students watching, be sure to kind of take these considerations, or I guess suggestions into consideration, and really reach out to people in your community, especially if you are at a solo practice or even if you are in a big health system. Know the resources that are available to you. Choose PT is a great resource as well. That is sponsored by APTA. So check that out. That is our big and the opioid epidemic movement within physical therapy. If you would like to continue this conversation offline, you can find us on social media, on Twitter at APTA Students, and then on Instagram and Facebook at APTA Student Members. We'd love to hear your comments, your thoughts on tonight's discussion. If you have any additional questions, feel free to drop them down below, and we'll be sure to include our contact information for Eric and Jake so you can reach out to them if you had any additional thoughts. Thank you all again for joining us for APTA Student Night. My name is Lindsay Durand, and I'm the Director of Communications for the Student Assembly Board of Directors. Thanks, and have a great night.